Good morning, everybody. Thank you all so much for being here. I'm Ann Rohal Andrade, and I'm the Director of Public Policy at the American Kidney Fund. We are so pleased to be hosting this policy session today, and our title is Policy and Innovation in Kidney Care. A little bit of background. At the American Kidney Fund, we're aggressively addressing the crisis in kidney disease. We're fighting on all fronts on behalf of the 35.5 million people in the US who are affected, and the millions more who are at risk. Our wide-ranging educational initiatives aim to help people prevent, slow down, or manage kidney disease. And most importantly for this session, our advocacy priorities focus on championing policies and laws that will help ensure the best health outcome for our community. Some statistics. Nearly 558,000 Americans are on dialysis, and Medicare provides health coverage to over 80% of end-stage kidney patients. So improving how Medicare pays for treatment is essential to support people on dialysis and encourage innovation. But as most of you know on this call, far too long, innovation has lagged behind in kidney care, and it's left many patients still relying on treatment that really hasn't changed over decades. So public policy plays an important role in making sure that healthcare systems keep pace with innovation. Today, we are fortunate to be joined by experts who will share how improving coverage policies help determine whether insurance, like Medicare, will pay for these new treatments and innovations, and how, most importantly, patients can access them. To address kidney disease in the US, we need more research. We need public awareness, earlier diagnosis, access to genetic testing and counseling, and additional treatments, and to improve understanding of why rates of kidney disease are much higher in underserved communities. Essentially, patients with kidney disease deserve and need choices beyond what's already available. Our panel today of experts will discuss ways that kidney care can advance despite these challenges that I've mentioned that pose a slowing of innovation. Our panelists will discuss new tools in development, opportunities to accelerate progress, and policies and strategies to promote and incentivize innovation. Care is important so that we can improve health outcomes for people living with chronic kidney disease. In addition to chronic kidney disease, we also want to address cardiovascular kidney metabolic syndrome, or CKM, and rare kidney disease. So let's get started. I am so pleased to bring our speakers to the stage. We're going to be joined first by Jennifer Friedman. Jennifer is the Vice President of Federal Health Policy Strategies. She is a former counselor to the Secretary of the U.S. Department of Health and Human Services and was a Deputy Staff Director of the Ways and Means Health Committee in the U.S. Congress. Jennifer has more than 20 years of health policy experience and, most importantly, Medicare experience. We are also fortunate today to be joined by Rachel Meyer, who is the Strategic Policy Advisor to the Executive Vice President at the American Society of Nephrology, or ASN. Rachel leads ASN's U.S. congressional advocacy and ASN's transplant agenda across all legislative, regulatory, and professional settings. In her prior role at ASN, she was the Senior Director of Policy and Government Affairs and oversaw ASN's federal policy portfolio, including Congress and the Centers for Medicare and Medicaid, or CMS. She also worked with the Food and Drug Administration, or FDA, and the National Institutes of Health, or NIH, to influence policies that affect kidney health, research, and innovation. Most importantly, and where I met Jennifer, she helped shape the Presidential Executive Order on Advancing American Kidney Health, and most recently, efforts to modernize our transplant system. I had the pleasure of working with Rachel on kidney policy when I worked at HHS. And we are pleased to have Dr. Sejal Patel join us today. Dr. Patel is an AKF ambassador. She's a researcher with experience in clinical practice, research, and patient advocacy. She's currently affiliated with Travere Therapeutics as a medical science liaison. In her former role as a medical science liaison at Eurofins Transplant Genomics, Dr. Patel partnered with the transplant centers to advance the use of innovative molecular diagnostics such as TRAC, T-R-A-C, and TrueGraph. This was for the non-invasive rejection surveillance. And last but not least, we are delighted to have Johanna Rodriguez Humbert join us today. Johanna is a pediatric rare disease advocate. She's a caregiver, she's a mother, and she's the founder of a nonprofit called Kaya Girl Legacy. Johanna shares her daughter Kaya's SPLIS journey to advance national efforts in early diagnostic, genetic testing, and pediatric kidney innovation. And lastly, we are honored to be joined by Senator Cory Booker from New Jersey. Senator Booker will share a special recorded message. He is also the lead sponsor of the Kidney Care Access and Protection Act. Before we get started, I want to thank the American Kidney Fund's 2024 corporate members for their support in making today's briefing possible. Our first speaker, Senator Cory Booker, was first elected to the U.S. Senate in a special election on October 16, 2013. Senator Booker and Senator Marsha Blackburn from Tennessee introduced the important Kidney Care Access Protection Act in September of 2025. So let's take a look at Senator Booker's message to advocates and participants in this webinar.
Hi, I'm U.S. Senator Cory Booker. It is great to be speaking to you all at this important briefing during Kidney Awareness Month, hosted by the American Kidney Fund. According to the National Institutes of Health, approximately 2 in 1,000 Americans are living with end-stage kidney disease. Unfortunately, too many of these individuals struggle to access the quality care or treatment they need and deserve. Due to outdated payment policies and regulatory barriers, patients lack access to innovative therapies that could transform their lives. And at the same time, dialysis facilities are struggling to keep pace with rising costs, forcing providers, particularly in the rural areas, to close their doors. I am committed to ensuring that every patient has access to life-sustaining care. That is why, in this Congress, I was proud to introduce the Kidney Care Access Protection Act alongside my colleague, Senator Blackburn, which would strengthen Medicare's kidney care benefits by ensuring fair reimbursement for quality care and improving patient access to innovative treatments, devices, and technologies. Additionally, alongside Senators Cassidy, Kramer, and Heinrich, I was proud to reintroduce the Restore Protections for Dialysis Patients Act, legislation that would ensure individuals with end-stage renal disease or kidney failure maintain access to their private healthcare plans. I remain committed to reducing the financial burden that is often placed on those living with kidney disease and advancing access to innovative therapies and treatments. I am honored to speak to you all today, and I thank you for your advocacy, for your work, for the kind of things you do to stand up that highlights the urgent needs of kidney patients. I believe what you are doing across our nation is so vital, and I'm happy to be in this fight with you. I know we can make for a better tomorrow for all kidney patients.
We want to really and truly thank Senator Booker for taking the time to record this message for our briefing today. We are grateful for his leadership and partnership fighting on all fronts for the kidney community, and most importantly, for being a champion for kidney patients. We're going to start our session today. I'm going to start with you, Dr. Patel. I think that you're important to this conversation because of your personal and professional experience with kidney disease, and you've lived both and understand the challenges. You've undergone 2 kidney transplants and a pancreas transplant. Could you share your journey with the audience today and a little bit about how that experience shaped the work that you do today?
Sure. Thank you for having me today. A little bit about my experience. with my own transplant and just my career, they kind of intertwine in the sense of I had finished medical school and I just was starting to prepare for my residency. I grew up as a type 1 diabetic, so medicine was not something new to me. So I finished medical school and I was preparing to embark, and I was feeling really dizzy and not normal, and having known what I learned, and I kind of diagnosed myself with anemia, but obviously needed blood work to confirm that. And so I called my primary care doctor, and he ordered some blood work for me, and sure and behold, it was anemia, and is almost to the level of needing a blood transfusion. So, he kind of sent me to different doctors, and no one could really figure anything out. So ended up having my hematologist oncologist, where I had landed, help me with iron infusions, and that wasn't working as well. And basically needed to have blood epogen, which is a drug that makes your body make blood. And so that really helped me and stabilized me. And my blood work was just pretty normal for the most part during this whole period, roughly between 6 to 7 months, just kind of trying to investigate what was going on. And I went to my endocrinologist for my normal follow-up with my type 1. And out of nowhere, my creatinine had jumped to the point of end-stage kidney failure. And we really didn't know what happened. So obviously, he urgently got me into a nephrologist, and we went to get a biopsy, and the biopsy came back after multiple pathologists read it as unknown cause of kidney disease, basically idiopathic. So from there, I was sent to the Mayo Clinic for a preemptive transplant. And when I went there, they had first, I was just going to get waitlisted for my kidney, but they decided I'd be a great candidate for pancreas as well because of my type 1. And so I was waitlisted for a pancreas and kidney. And so I was very, very fortunate to have not waited as long as a normal kidney transplant patient would normally have to wait, which is 4 to 6 years, even longer, depending on your blood type. And so received my transplant, and after 9 months. So was able to get transplanted and was able to pursue my career. And I moved into more of a research focused career, just with my background, and worked in transplant medicine. And 10 years later, I needed a second transplant. So during that second time, I did have to wait that 4 to 6 years. So, I feel like with how innovation is moving and how things are advancing, I think some of these wait times may decrease, looking at how many new things are happening. And it's just a very exciting time for us. So, having lived through this, I think, things that are happening and emerging are very needed in this area, just with research and innovation. So
Thank you. And your story really puts a light on how long the journeys can be for some patients. It's not just one transplant, sometimes it's more than one. And yet you continue to work in the research and innovation space. So we thank you for that. Johanna, let's move to you. You bring an incredibly important caregiver and parent perspective to the conversation today. Can you tell us a little bit about your story, your experience with your daughter, Kaya, and her diagnosis, and maybe a little bit about how advocates and policymakers can empower patients and close education gaps, especially in underserved communities?
Yeah, absolutely. Thank you, Anne, and the American Kidney Fund for having me and giving me the opportunity to share our Kaya girl's story. So our daughter Kaya was born with a rare genetic condition with the acronym of SPLIS, which stands for Syncytium Lias Phosphate Insufficiency Syndrome. It's a long word, so sorry. When she was just 5 weeks old, we were given the diagnosis, and like many families facing a rare disease, our journey began with confusion, unanswered questions, and just a lot of learning in real time. Kaya eventually did develop end-stage kidney disease. At the age of 6 months old, we began peritoneal dialysis within the hospital setting, learning to administer it on our own so that we could transition to the home. As her mother, I became not only her caregiver, but also her medical coordinator, her researcher, and her advocate. What I learned very quickly was that when a child is medically fragile, the parent becomes a medical chart, the alarm system, and the translator for a child that can't raise their hand and say, "I need help." Families are often navigating incredibly complex medical systems while also carrying the emotional weight of watching their child fight for their life. This experience is what led me to found Kaya Girl Legacy, where we focus on education, early diagnosis, and increasing access to genetic testing and genomic awareness. One of the most proactive things we can do moving forward is to expand education. Access to genomic sequencing, not only when someone is sick, but when they also appear healthy. When genomic literacy becomes part of routine healthcare, even during our annual wellness visits, families become equipped with information that can guide healthcare decisions and family planning long before crisis occurs. For rare disease families, you're often searching for answers while the disease is already progressing, and earlier knowledge can very much so change the trajectory of that path.
Thank you, Johanna. Your story is so powerful, and the way that you honor Kaya through your advocacy is so, so important and admirable. So we thank you.
Thank
Rachel,
you.
let's bring you in next. From your perspective, how is the American Society of Nephrology, or ASN, driving progress to expand treatment options for kidney patients?
Thank you so much for the chance to work with AKF today and the other 364 days a year to help to kidney care.
Yeah.
As I think you and others have already highlighted, research is really a critical missing piece in delivering new choices and better choices to patients. So when we think about how to drive progress, we at ASN believe that we're best doing that, expanding treatment options for patients, when we're working with patients. A new initiative that we're really energized by ASN is called the Transforming Kidney Health Initiative, a research report that AKF and others were integral in helping to develop. As Dr. Patel highlighted, and I think this report reflects, this is a really exciting, promising time for research and innovation. So this report basically outlines a set of research opportunities to advance early detection, prevention, novel therapeutics, basically transformative approaches to kidney diseases and kidney failure. And investment in these areas, the report's authors believe, will really spur the kind of development of breakthrough technologies and next generation therapies to improve the lives of people like Kaya, Johanna's daughter. So we're putting together a bold funding request to Congress. I'll come back to the money in a minute. But I think what's so powerful about this report and this approach is that this is not just our thinking at ASN. The Blue Ribbon panel that produced this set of funding recommendations to invest in research was led by our president, Samir Parikh, and my colleague, Ryan Murray. But it also included the American Kidney Fund, ASPN, ANNA, NKF, and AAKP. So you have patients, research scientists, pediatricians, and clinicians who are all contributing from their lived experiences, the bench, and the bedside. I think one of the interesting things is that when this Blue Ribbon panel looked at the state of kidney research funding, they found that compared to other serious conditions like Alzheimer's or cancers or HIV, which get hundreds and thousands of National Institutes of Health dollars allocated towards their research funding per patient, in comparison, we only have about $20 per American living with kidney disease. So it's evident how a similar investment in kidney research could have a really transformative effect for Americans as people who are affected by some of those other conditions now enjoy. So we are coming back to the money. We are asking Congress to invest $1.8 billion, and that's with a B, for kidney health research across the entire federal government. So not just the National Institutes of Health, the Department of Veterans Affairs, the CDC, even the Department of Defense. And to begin with, we're asking for an initial investment of $1 billion in fiscal year 2027 for kidney health research at the National Institute of Diabetes, Digestive, and Kidney Diseases. But again, what's going to make this effective is not just ASN, it's all of us together. So I hope that anyone listening and the organizations that you're involved with will join ASN, AKF, and others in this effort. By bringing a united voice to Congress, that's how we're going to be effective in moving the needle on the dollars that will develop the therapies that patients have been waiting too long for.
That's excellent. And you make a really good point that collaboration, across the kidney care spectrum with all the stakeholders at the table is going to make a difference. And I think that report, it has data, and we know that data drives policy. So that's exciting. So we're going to move on to Jennifer. Uh, Jennifer, you're here today to talk about the Medicare end-stage renal disease, or ESRD bundle, and its limitations in terms of supporting innovation. And for those who are new to the policy space, could you briefly explain what we mean when we say bundle? And then tell us a little bit about what happened with Korsuva. Korsuva was a breakthrough drug that was designed to treat chronic itching in dialysis patients. What can we learn from that experience, and how can we better incentivize innovation so that Medicare ESRD patients have access to the best care possible?
Sure, great. Thanks so much, Anne, and thanks so much for the invitation to be here today during Kidney Month. It's really nice to be here with everybody. Wish we could be in person, but it's nice to be here virtually, and I know that's more convenient for everyone. So yeah, going back in time to when the bundle was created, why was it created? Beforehand, Medicare paid for the dialysis separately from how it paid for the drugs, including Epogen, which Dr. Patel mentioned in telling her story of her journey. And Epogen, as she mentioned, is to treat anemia. And the way Medicare paid for drugs, it created incentives, perhaps for dialysis providers to provide more of those drugs if they were able to make money off of that. Perhaps if Medicare paid more than what the dialysis providers had to pay for to buy the drugs, if there was a way for there to be a margin there. And so that led to there being an incentive to dose more and more of the drug if there was an opportunity to make money off of it. And so the challenge there was with anemia, with Epogen, there's a black box label on Epogen that warns if you use Epogen to raise red blood cells too high, it puts the patient at risk of blood clot, stroke, heart attack, and death. And so that's obviously very problematic. And so the bundle was designed to create one payment for the dialysis treatment and the drugs in the lab, so to encourage dialysis facilities to be more efficient in their delivery of care. So rather than having incentive to dose higher and higher levels of Epogen, there would now be incentive to be more efficient in their use of Epogen and to remove that risk for patients. And then it was paired with a quality program, so to make sure that on the other end, you wouldn't have stinting of care where there'd be then, because otherwise you create an incentive to dose too low of an amount. So that's what the bundle is. It's all the money bundled together. So it was created back then, about, not quite 20 years ago, to solve the problem that existed then. And this is when I worked in Congress, and it was something that throughout my career I've been very proud of. But now we fast forward to our current situation, and while it was the right approach for the moment then, we now face the issue of, as Anne talked at the beginning, we're not seeing the innovations in kidney care and ESRD that we'd like to see. We have solutions happening and cures, and we have worse outcomes in ESRD than we have in kidney cancer, and we're not having the innovations we'd like to see. So getting to the example of Korsuva, which is a cure for chronic kidney disease associated pruritus or chronic itching, as Anne mentioned. When that came to be, the Centers for Medicare and Medicaid Services, CMS, grouped that new drug in the same payment category as antihistamines like Benadryl, which is ineffective when dealing with chronic itching. And that move resulted in insufficient reimbursement. So first, for Korsuva, they received 2 years of payment, of an add-on payment, and then it moved to the payment system that it's currently getting, where each treatment, for each dialysis treatment, there is an 11 cents add-on for Korsuva, even though the average sales price for Korsuva is about $50. And for dialysis facilities, they receive that 11 cents across every single patient, even though not everyone receives Korsuva. And the theory there is that they have to see enough patients that don't receive Korsuva in order to cover the one patient that does receive Korsuva. And the trouble there is not every facility has enough patient volume to make the finances of that work out. So what happens is that dialysis facilities will put in place policies and procedures to try to manage who's going to get the Korsuva and who's not. And so that ends up being problematic. So the lessons learned from this are that we need different policies to improve access to innovation. Because really CMS is asking innovators to basically take on the risk of all the research and development when they don't know for certain how they're going to be reimbursed at the end of the day. For instance, that process where Korsuva ended up being treated the same as Benadryl, that was a whole black box process, and the manufacturer of Korsuva didn't know that's how they were going to be reimbursed in the end. Other things that could be done to improve on this would be to make sure that the payments are happen for a longer period of time, changing that payment process at the end so that it's not this 11 cents per every treatment, but rather that it's a payment that's specific to the treatment for the person who's getting the Korsuva. And those are some of the different things that could be done to improve payments for innovative drugs. I'll also say we were talking about drugs here, but there's obviously also issues with regard to devices in terms of improving incentives for innovative devices as well.
Yeah, and that was such a helpful explanation. It's a complex topic, but I think you broke it down well. And I remember hearing somebody say once that 50 years ago or so, if you were having dialysis, you'd be sitting in a chair reading a magazine, and today you're on your smartphone, but there's not a whole lot of change between those times. So thank you so much.
Yep.
Rachel, let's come back to you. You mentioned a little bit about the collaboration in the Transforming Kidney Health Research Project, but tell us a little bit more about how partnerships between advocacy groups, researchers, and policymakers can keep that pipeline of innovation strong.
Yeah, thanks so much, Anne. I think you use the most important word in effective advocacy there, and that's partnerships. In my experience, effective advocacy is most often a long-term and a collaborative effort that involves listening and creative thinking from many different stakeholders, including policymakers themselves. I mentioned earlier that patient organizations, including the American Kidney Fund, scientists, and clinicians were all involved in developing the recommendations in the Transforming Kidney Health Research Report. But critically, those who wrote it also engaged a wide variety of federal research funders, including those at the NIH and the VA, to get their perspectives on what the research needs and the really promising breakthrough opportunities are. Turning to Congress, I feel like policymakers there are really best positioned to take bold asks to support innovation seriously and feel empowered to actually deliver on those asks in the form of money when the requests come from a broadly representative set of organizations that bring together different perspectives that are all united. And that's why, just as an example, it was so important for the Transforming Kidney Health Research Blue Ribbon panel to be made up of a bunch of different perspectives, including patients. Coming back to kind of the nature of collaboration with policymakers, it's unlikely that we're going to get an immediate yes on our bold ask for $1 billion. But the goal as we start out this process is really to get Congress to engage with our community so that we're all thinking together about what are the pragmatic ways that we can fund and achieve our goal of really improving the lives of Americans with kidney diseases by investing in and funding more innovative therapies. So that's one example involving Congress. I think another good example of the importance of partnership and collaboration between advocacy groups and policymakers is the Kidney Health Initiative, which is a public-private partnership that ASN and the Food and Drug Administration established more than a decade ago that really is a multi-stakeholder partnership to accelerate the development and improve patient access to emerging therapies that need FDA approval. It basically works as a membership organization where patient groups, pharma, device makers, even some of the xeno companies now can come together and identify as a group where are there unmet patient needs, where product development is desired, and how can the FDA in a legal context provide more guidance to companies with patient input about what they need to see as a regulator to move these drugs forward. So how does this actually work? A concrete example is an IgA nephropathy. Almost 10 years ago, the patient group said, hey, we need treatments. Our kids are sick and we don't have anything great to really address their problems. So the Kidney Health Initiative brought those patient groups together with scientists, companies, and the Food and Drug Administration to design endpoints for clinical trials. Eventually, those endpoints actually got used by the companies. And today the FDA has approved more drugs in IgA nephropathy than you can count on one hand, which is so exciting for the patients and families that were waiting way too long for that kind of breakthrough. So again, I think when we think about how to be effective advocates, we need to think first about partnership and collaboration and articulating shared goals with those who are in the driver's seat, whether that's in Congress or in the regulatory agencies.
Yeah, that's excellent. And I'm glad you brought up the ASN Kidney Health Initiative. I wanted to highlight the key KHI Patient and Family Partnership Council, which is a group that also helps advise and share, I think, education about what quality of life is like for patients with kidney disease, regardless of what stage they're in, because there isn't a cure. And I think educating Congress and policymakers about that is really important. Jennifer, let's talk about bipartisan policies and smart regulatory frameworks that can create an environment where innovation thrives and patients can get access to things that will make them better, faster. We talked about a little bit about the Kidney Care Access and Protection Act with Senator Booker and other bills. Can you share a little bit about that with us?
Sure. Yeah, I would love to tell you a little bit more about the Kidney Care Access Protection Act that Senator mentioned at the beginning. So that's with Senators Booker and Blackburn in the Senate, and then in the House, it's Congresswoman Sewell from Alabama and Carol Miller from West Virginia. And it has a number of provisions in it that would advance innovation, some of which I sort of mentioned at a very high level. One is that it would extend the period of time where there's an add-on payment for drugs. That gives a little more certainty to innovators to know that there'll be a return on their investment at the back end. Another piece is that it would solve that problem of Korsuva or other drugs only getting that 11 cents for every single patient by making sure that the payment is attached to the actual patient getting the treatment, getting that actual innovative drugs.
Mm.
Another one that I didn't mention that I think is really cool is that it would say drugs for diseases that are not related to dialysis. So let's say like for cardiovascular disease, you mentioned CKM at the top. Things that are not related to dialysis, it would make it clear that those would be outside the bundle. So if a drug came along that was for cardiovascular disease, which we know, as you mentioned, is very closely related, that would be paid outside the bundle. So there wouldn't be a concern on the behalf of the manufacturer that if they create a drug that would treat that, that it would end up being bundled in, meaning there'd be no additional money for it. They would then have confidence that they developed a drug in that space, it would get a separate payment, and they would know that then would be a return on their investment there. So I think that's a really huge development there. That would be great if that happened. Another piece is it would extend the add-on payment for innovative devices. So that would be helpful. And then it would also extend that for innovative devices that are in center. So currently there's an add-on payment for innovative devices that are for home dialysis, but it would also recognize that a lot of patients do go in center, and to the extent there's a device that can improve care for them, recognizing that that's what your treatment is. It's through the device that if there's an innovation there that can improve outcomes for you, that should also be encouraged. So those are many pieces of it. And then a finally piece of it is recognizing the fact that over half of ESRD patients are in Medicare Advantage plans, and all of these payments are flowing through the system that's for people in traditional Medicare. So it's making sure that all of these innovation payments also are following and working for those patients who are in Medicare Advantage. So that's also a big piece of it, is making sure that these innovation payments also happen in Medicare Advantage. So those are all the pieces that are in that bill. So I think there's a lot of really cool things there. And one thing I also wanted to mention, I know that this is something Rachel would feel strong has mentioned as well, is that in all these pieces, it's also really important to make sure that the patient voice is recognized. And so this bill came together through a coalition that's got a lot of healthcare stakeholders, kidney care stakeholders, including patients. And so that's really important. But there's also a piece for you all that are in the audience of recognizing that there's also a piece of advocacy you all can do every day when you're in your care settings, of asking your healthcare providers if there are any barriers they see in their ability to provide you with innovative drugs and devices, and if there's anything more that can be done in your daily care. And just sort of wanted to call to your attention that for you all, Medicare requires that each dialysis patient has an individualized patient care plan, and that your needs and wishes and goals are taken into consideration. And that's required under Medicare law and regulations. So I encourage all of you, the patients in the audience, to pursue advocacy, both at that macro level with policymakers, pushing for the funding that Rachel's talking about, pushing for this bill that Senator Booker is pursuing, any other things that you think are important, but also to pursue it personally in terms of your own care plan. And thank you again for letting me be here today.
No, that was very helpful. And you raise an important point that patients have to be at the table. They have to say what they want. What do they need to improve their quality of life? And I think also that innovation isn't just treatments, it's how do we pay for those treatments? So I really appreciate your insight. Dr. Patel, you are, as we mentioned, a scientist and a patient advocate. Can you talk a little bit about breakthrough or emerging technologies that you think probably hold the most promise for improving transplant success and quality of life, which we, really, really want to address for all of patients? I think we're having a sound issue. I wasn't sure if it was on my end, but
Is that okay?
yes, thank you, Dr. Patel. Go
Okay,
ahead.
sure.
Yeah.
No problem. So, I was just saying, when we talk about like the breakthroughs and emerging technologies in kidney care and transplant today, I think we have a lot of really exciting things that are emerging and happening. We're really changing the way we think about patient care and outcomes. There's new and exciting things. There's like precision medicine and genetic testing that are making a huge difference today. Like there's the high resolution HLA tape typing, epitope matching, and pharmacogenomics are allowing us to really tailor immunosuppressive therapy to help, really match each patient's genetic profile. So rather than that one size fits all approach, I think this is really helping reduce that rejection risk, improving that graft survival. And also beyond that, there's also single cell RNA sequencing and other multi-omics tools also that are letting us really see which immune cells might attack a graft even before traditional tests are even picking that up. So I feel like we're just moving into a whole new level of like personalization. So I think that's very exciting. And also just all the next gen monitoring tools that we have. They actually can help us predict rejection before it actually happens. So there's the donor-derived cell-free DNA technology, the urinary exosomes, also blood-based gene expression panels are also giving clinicians early warning signs so we can intervene sooner. Often these are without invasive biopsies as well. So that, really helps patients, recovery, and they don't have to sit, take away from their own life recovering from these biopsies as well. There's also these AI-powered tools that are really integrating lab results, immunology, and clinical data to really help us predict that long-term graft survival as well. And it helps us make smarter decisions about patient care in general. And then on the therapeutic side, I think there's just so many new drugs that are emerging for rare and genetic kidney diseases. I think there's new targeted therapies for C3 glomerulopathies and also IgA nephropathy. Also the other rare diseases like FSGS that don't have treatments. I think it's just a really exciting time right now. And just we're addressing these unmet needs that previously had very few options. So it's very exciting. We're also kind of looking at new approaches and moving from just lab into early trials that are really offering hope for these inherited kidney conditions that could one day just be treated as at the source. So not just managed symptomatically. So I think it's really exciting. We're looking more at the upstream signal of a lot of diseases as well. And I think a lot of new technologies are also occurring. We're looking at wearable sensors, new dialysis formats of not having to sit in a clinic and have dialysis as well. I think there's a lot of new variables out there that we can watch and allow us to have continuous kidney monitoring, which is pretty exciting. And then organ on a chip is something that I was kind of looking into that it's more accelerating that personalized drug testing. And then, the whole xenotransplant world is also very exciting because we're having gene edited pig kidneys that are starting to expand that donor pool in ways we never really imagined. So, a lot of new clinical trials are testing and looking at different innovations from genetic testing to innovation and precision therapy. So, I think it's really all about, prolonging that graft survival for transplant patients and helping prevent complications that occur from the immunosuppressions that we're all taking. Most importantly, I think the quality of life for patients, that's one of the pieces that if we're doing fine, people don't really think about that or really pay attention to that because we've got a transplant and we're seemingly doing well or our drugs are any conditions that we've had are being managed, but thinking more into the area of like how we can have better quality of life for these patients as well. So I think all of this is really exciting, and moving into more personalized medicine is always something that I think will really help patients in the future.
Yeah, that's excellent. And I think I would say for patients and caregivers that are listening, what resonated with me is predicting rejection early and particularly avoiding a kidney biopsy, which we know carries risk and especially infection risk for transplant patients. So thank you for giving us hope. That was really excellent. Johanna, I want to close by coming back to you. As we've talked about, am a living donor to my daughter, and I have learned so much from you and Kaya and her journey. Can you talk a little bit more about being a caregiver for a loved one and how that helps other families through the process? And maybe a little bit about what meaningful progress in diagnosis and innovation means to you personally, and then for others with kidney disease who are on the path from beginning to end stage.
Yes, of course. Meaningful progress for me would mean fewer families are spending years searching for answers while their child's health is declining. For many rare diseases, the diagnosis journey can take 5 to 7 years. And during that time, families are seeing symptoms unfold without any real understanding of why it is occurring. Earlier diagnosis can change everything. It allows families to connect with different specialists sooner, to prepare, and in some cases to change the course of care. Innovation in kidney care and genomic medicine means earlier answers, better monitoring tools, and hopefully, as Dr. Patel shared, one day targeted therapies for rare conditions like SPLIS. But progress also means that you're building a system, one that supports families emotionally and practically. Because caregiving at this level is one of the most intense responsibilities any parent or human can carry. Throughout my journey with Kaya, my faith carried me a great deal, and advocacy has become one of the ways that I continue to mother her. It's a way for me to turn the love that has nowhere to go into action that could really impact and change the trajectory of other families' lived experience. So thank you so much, you guys, for having me, and I really appreciate being here with AKF and all of you.
Thank you so much. And again, thank you for your courage in honoring Kaya Girl. We are so grateful. Before we wrap up, I want to ask each of you to share a little bit about something that excites you about the future of kidney care. And I know that's a loaded question, but Johanna, let's start with you since you just finished.
Yeah, I think what excites me the most is kind of like what we've all talked about, right? Genomics, precision medicine, patient advocacy are the beginning to intersect in such powerful ways. We're all kind of speaking the same language at this point. So Dr. Patel shared things that just excite me, and I'm sitting on the other side of the aisle right now, right? No longer walking the path towards the transplant with my daughter, but with loved ones who are still experiencing dialysis. So my hope is that for the next generation of children that are born with rare kidney diseases, they'll benefit from all these breakthroughs that just simply did not exist 2 years ago when Kaya was born. And it's also crazy to hear all of these advances and know that my daughter was only born 2 years ago, right? So I'm hopeful. I think sitting here and ensuring that we're making such great progress in relation to kidney care, it's one way of ensuring that families are not left searching for answers alone.
That's excellent. I wish I could coin that entire explanation and share it with family. Rachel, you have been a tireless advocate at the American Society of Nephrology for so many years. Tell us what you think excites you about the future.
So to build on those who've spoken before me, I think we don't say it often enough that transplant is the optimal therapy for most people with kidney failure. Johanna just explained why better than I could. And I think Dr. Siegel outlined some really exciting technology to improve patients' access and outcomes. But I'm really excited about the promise of xenotransplantation to expand our organ supply, which really means expanding patients' access to that therapy for the 100,000 Americans who are waiting. You know, we've heard really loudly and really clearly from patients that xeno is an innovation that they want pursued. And I think the rest of the community, all of us, really need to listen to that, honor that, and do what we can to help move it forward. And as Dr. Siegel referenced, with multiple companies underway with FDA clinical trials, I think we all have reason to be optimistic about improving access to transplantation, whether that's through xeno or through traditional human allograft in the future.
Yeah, I agree that xeno is so exciting. And you think about, as you mentioned when you first started talking about innovation in cardiology, and when we have pacemakers, kidney disease needs to step up to the plate. So thank you so much. And Jennifer, tell me a little bit about what excites you about the future.
Sure. I'm going to cheat and say two things. And first, I mean, Dr. Patel listed like a whole bunch of really cool things.
Yeah.
But I worked for two different medical device companies. So I'm going to say that some of the different technologies that are being developed there with regard to the artificial kidneys in terms of like the wearable backpack kidneys and that kind of stuff, I think is really cool. That's being developed. And then I think something, again, that you referenced at the beginning, Anne, all the work on CKM and the notion of being able to better manage comorbidities like cardiovascular, both upstream and then for folks who are at end stage, and being able to better manage that, because cardiovascular disease, we know, is the leading cause of death for people on dialysis, and also a big contributor to the Medicare costs for managing care for this patient population. So the thought that there's now such a big focus on managing that complication comorbidity for this patient population before they come to end stage and when they're on end stage, and there's that focus there, I think is really exciting. And the fact that it's also consistent with Secretary Kennedy's MAHA agenda, and maybe it's even got some alignment there. That's kind of nice to see. So I think that's also a really exciting space. And I know that you all are doing work in that space with the American Heart Association, and NKF is also doing work in that space. So I think that's something that I'm also excited about.
Yeah, that's great. And especially with your insight working for device companies. You've seen it from the ground up. It's not just something that we chat about for the future. So that's exciting. Dr. Patel, tell me a little bit about what excites you about the future.
Yeah, for sure. I feel like everything excites me. Like everything is just so exciting. I couldn't like pin down one thing. And I'm going to be a little selfish here, but and also extending out to other patients that are going through similar situations as me, and anyone, dealing with any kind of chronic illness. But I think, it just excites me about the possibility that it holds for all of us. And having gone through so many multiple transplants, I think firsthand, I know how life-changing it would be for, to have drugs with fewer side effects, or, reducing the daily burden of taking so many medications, or, ultimately, I would love to live with one organ for a lifetime. I think that would be the ultimate goal for a kidney transplant patient like myself. So for me, I think it's just the freedom, the stability, the quality of life that comes with it, and just being able to focus on living rather than having to manage a disease that's just constantly causes worry. And it's like worrying about the next complication from what we're already dealing with. So I think, that's what really makes this work so exciting for me and really deeply personal. So.
Yeah, that was great. And the most difficult job for me today as moderator is that we don't have enough time. There's so much to discuss. So with the 5 minutes and some change we have remaining, let's do a little Q&A. Rachel, how can home dialysis be expanded by updating regulations, CMS conditions for coverage, all those fun things?
Great question. Home dialysis has grown a lot in recent years, and I think we believe that there's still a lot of room for it to continue to grow for the patients who want that option. Something we're doing at ASN is making sure we're providing better education so that health professionals are equipped to say yes when a patient wants to do that. I think there are also ways we can utilize new technologies, or perhaps not so new technologies, like remote patient monitoring, to help clinicians keep one eye on their patients who are going home, and to give confidence to those who are at home that they'll be getting a similar level of care, possibly with a better quality of life if they make that choice. Thinking about the conditions for coverage, those really haven't been updated since the mid-aughts. That's a long time ago. Technology has changed, science has changed, how we value patient preferences and what they want to do with their care has changed. So I think we have an opportunity as a community to really go back and look at those and understand how can we modernize them, make them more efficient, and make them more patient-centered, so that dialysis organizations are able to deliver what people want in their own kind of care paradigms.
That's excellent. And then, so that leads to a question then for Jennifer. How can the Kidney Care Choices Model, or KCC, coordinate care and delay dialysis and transplant, kind of to Rachel's point and her goals?
How can it, in terms of home dialysis or just generally?
I think just effectively coordinating care and delay dialysis and transplant. So in other words, how can it improve quality of life, and how can it benefit kidney patients, the model itself?
Well, I think that it's got such great potential. I mean, it's already doing a lot of great things, but in terms of, encouraging that partnership between the dialysis facility and the physician, and making sure that the physician is thinking about the patient before they get to dialysis. I mean, I think someone mentioned it, maybe Rachel mentioned the notion of, transplant is ultimately the goal, but really the goal is making sure you don't get to the point where you need the transplant. So that you don't, you want to have an optimal start if you get to ESRD, but really the goal is that you don't even get to ESRD. So if you are in CKD3, that you don't progress even further. And so that is, I saw on the edge of my screen some clapping, but from Rachel.
Right there with you.
So that's really, that is really the point, right? Like, so that patients, you have that education further upstream, so patients are realizing where they are in terms of their kidney disease, and they're not progressing further. But then if they do progress further and they are getting to that point where they're at CKD5, that then they are educated about their choices. And so they are educated about, is home what they want? Is it peritoneal dialysis or hemodialysis, home hemodialysis, et cetera? And then they can then enter into dialysis educated about those choices, and all of that with an optimal start, or perhaps getting a transplant the way Dr. Patel was able to at the front end. And so all of that being a very educated and thoughtful journey. And I think that the model can help to sort of map that out, and it's being tested, and hopefully that's something that can then expand in terms of options that can be available to more folks. And as more and more physicians experience that, and as Rachel mentioned, and having more physicians when they go through the residency, more nephrologists as they go through the residency, learning about some of these options and learning about home dialysis, et cetera. I think that's also very important.
Yeah,
That's great. And in the short time we have left, Dr. Patel and Johanna, just give us a real quick response to how patients and advocates can help speed up innovation. I know, Dr. Patel, you mentioned the patient story, the patient journey, educating people. Just each of you, give me a couple sentences about what you think we can do as patients.
Do you want to go first, Dr. Patel?
Yeah, sure. Thanks, Johanna. I think we have to really remember that as patients, we're not passive observers in this journey. I think we have to think of ourselves as essential partners. So I think sharing our stories is really important. I think, participating in clinical trials, registries, and studies to help be part of that research and advancement of new treatments, I think is very important. And also just raising our voices, demanding attention, and also just insisting that innovation moves faster and smarter and more patient-centered. And we're not here to just be passive, but it's our voices really help make that future kidney care brighter and safer and more hopeful for everyone. So I think that's really important.
Yeah, the only thing The only thing I would add to what Dr. Patel said is advocating for policies that support our research funding, genetic testing access, and equitable healthcare navigation. I think when patients, clinicians, researchers, and policymakers all work together, to the point of what we've all said, innovation moves faster and ultimately reaches the families who need it most.
I absolutely agree. And then Rachel, we've talked about needing to increase funding and the importance of public-private partnerships. So KidneyX that ASN has championed for years, how can we maintain the KidneyX program when federal funding for research is being cut pretty significantly?
Yeah, thanks, Anne. So for those who don't know, KidneyX is a complementary mechanism that aims to take research to bridge it from the level of the NIH, where it's shown promise, to actually help products be developed that can get into the hands of patients. And I think Congress has robustly supported KidneyX since its inception, precisely because it has heard from patient groups and patient advocates. Johanna said it better than I possibly ever could. So raising your voice, telling Congress, I'm sure many organizations out there, including AKF and ASN, have an easy mechanism on their website to do this, that you want to see that support for kidney innovation sustained and continued to bridge what we have proven is possible on the bench to actually get to the bedside to patients.
Yeah, 100% agree. And I think the word public policy or policy can be nebulous and confusing to people, but it's really just educating patient story that drives the policy. So I am so grateful to all of you for joining us, for sharing your professional work and your journeys. This will conclude our panel, but kidney patients, caregivers, and professional organizations, research, and medical communities have our work cut out for us. But together we can keep driving progress. There's strength in numbers, and the passion I see in the kidney community is some of the strongest I've ever seen in the healthcare space. So thanks again. Our next session is technological advances and its impact on kidney care. That session will begin at noon, so you have a little bit of a break. In the meantime, you'll see a brief survey pop up. And if you wouldn't mind, please taking a minute to fill it out, let us know how we did, so that we can use your feedback as we plan future sessions. But thank you everyone so much, our panel and the audience. Stay safe and have a wonderful day. Take care.